High-risk newborn, classification of high-risk infants. I'm not going to go over all of them, guys. I'm just going to go over the most important ones, but you guys know you're responsible for everything. Low birth weight infant. That's an infant whose birth weight is less than 2,500 grams, regardless of the gestational age. Appropriate for gestational age infant. That's an infant whose weight falls between the 10th and 90th percentile on the intrauterine growth curve. Intrauterine growth restriction. This is found in infants whose intrauterine growth is restricted, sometimes used as a more descriptive term for small for gestational age. Sometimes it's used interchangeably. Large for gestational age. This is an infant whose birth weight falls above the 90th percentile on the intrauterine growth charts. Preterm or premature infant, that's infant born before 37 weeks gestation. Full-term infant, that's an infant born between 39 and 40 weeks of gestation. Post-term infant, post-term infant, infant born after 42 weeks of gestation. And fetal death. This is death of the fetus after 20 weeks of gestation and before birth with absence of any signs of life at birth. Let's jump over to page 617. Neonatal skincare. Everyone there? Bathing, giving the initial bath. You're going to assess to ensure that the infant has a stable temperature for a minimum of 4 hours before the first bath. Do not completely remove the vernix. Allow it to wear off with the normal care and handling. Routine, make sure you're using a pH neutral cleanser or soap no more than every 2 to 4 days. Adhesive, decrease use as much as possible. Don't use adhesives unless you absolutely have to. Their skin is very, very, very thin and fragile. Prevention of skin breakdown. Use barrier cream in the diaper areas such as the groin and thighs to reduce urine irritation. Diaper dermatitis. You want to maintain clean, dry skin, use absorbent diapers and change your diapers often. For developing dermatitis, apply a generous quantity of zinc oxide barrier. Notice I highlighted the zinc oxide. Treat Candida albicans with antifungal ointment or cream. Remember, this is a fungal infection. Avoid powders and antibiotic ointments, especially powders. Don't ever use powders, and you have to teach that to the parents because in many cultures, they like to, put powders in the diaper areas, and you have to teach your parents that is a no-no. Throw it away.
No baby powder ever?
No, ever. Ever. I can't tell you about this on the recording, but remind me afterwards and I'll tell you why. I'm not trying to get sued. All right. All right, infections acquired from the mother before, during, or after birth. Now, for HIV, I want you guys to pay attention to this. In developed countries, avoid breastfeeding an HIV-positive mother. This has been seen so many times on NCLEX, ATI, Hesta, you name it. You need to know that if mom is HIV positive, she cannot breastfeed. Gonorrhea, preventative measure. Apply prophylactic medication to the eyes at time of birth. That was one of your questions on the Kahoot, right? Mm-hmm. Herpes simplex virus. You're going to use contact precautions in addition to universal precautions. Therapy with IV acyclovir is initiated if culture results are positive or if there's a strong suspicion of herpes virus infection. Talk about tobacco. Low birth weight is the most widely recognized effect of maternal tobacco use. Alcohol, you have to know these signs and symptoms. Signs and symptoms include jitteriness, increased tone and reflex responses, irritability. Seizures are common. Fetal effects of alcohol exposure vary from subtle learning disabilities to obvious facial features and growth abnormalities. Fetal alcohol syndrome is the most severe type. Affected individuals have abnormal facial features. You got to know what these facial features are, guys. Small eyes or short palpebral fissures, thin upper lip, flat midface, and indistinct philtrum. Growth restriction and neurodevelopmental deficits with or without a confirmed history of maternal alcohol consumption. I'm highlighting the ones for testing purposes for NCLEX. This is what's been seen. They give you these symptoms and you have to know what, they're gonna ask you what you suspect. You better know that's fetal alcohol syndrome. Infants who do not display the signs of fetal alcohol syndrome, but are born to mothers who are heavy alcohol drinkers, have significantly more tremors, hypertonia, restlessness, excessive mouthing movements, crying, inconsolability than infants of substance abuse mothers who do not consume alcohol during pregnancy. There is no safe amount to tell a mom how much alcohol she can have. So if you get a test question with a mom saying, oh, I'm pregnant, can I have one glass? How many glasses of wine can I have, or alcohol? There's no safe limit. There's no safe amount that's ever been recorded. Safety alert. The use of naloxone Narcan is contraindicated in infants born to opioid addicts because it can cause severe signs and symptoms of neonatal abstinence syndrome and even seizures. So we can't give Narcan to the infant. RH incompatibility.
So we can't ignore him. The final thing, we can't.
Yes, to the newborn infant that was born to an opioid addicted mom. Now remember, guys, I keep telling you this. This is why when you work in the medical field, you cannot go back on what you see. You have to go by the textbook because that's what you're being tested on.
What about if what about if the mom just got paid meds and the baby came out kind of sickly? Like right after you gave them.
That the infant will be treated symptomatically. They're going to be treated symptomatically. Everyone here? All right. RH incompatibility. I'm not reading all of this. I'm going to get to the point. This is what you guys need to know and what you guys need to understand. Under normal circumstances, the process of isoimmunization has no effect during the first pregnancy with RH positive fetus because the initial sensitization to RH antigens rarely occur before the onset of labor. That's important. So if mom is RH negative, and that's the only time we have a problem, if she's RH negative. If she's RH positive, we're good. We're always good. The only time there's an issue is if she's negative. So if she's negative and she gets pregnant, baby's RH positive, that first pregnancy, she's fine, the baby's fine, because there hasn't been time for those antibodies to be formed, right? It's the following pregnancy. And the reason there's an issue with this, what happens? You're in college, you're living your best life, you get pregnant, you decide not to keep that pregnancy, you move on with your life, and that baby was RH positive, right? Now you get married, you settle down, you're pregnant again, this baby's gonna have issues. And so what happens very often when you're getting history and you're asking the woman in front of her spouse, the spouse may not know that she had a previous abort, that she had a previous pregnancy. Sometimes women don't even know that they were pregnant. They'll think that they had just a heavy cycle and they really had a miscarriage, okay? And the reason I'm telling you all of this is that if mom is RH negative, she's gonna get, I just popped my tongue, I'm sorry. She's gonna get RhoGAM. But let's keep going, I'm getting ahead of myself. However, with increased risk of fetal blood being transferred to the maternal circulation during placental separation, maternal antibody production is stimulated. During a subsequent pregnancy, there's a reason they put that word subsequent. That means there was one before, right? Okay. During a subsequent pregnancy with Rh positive fetus, these previously formed maternal antibodies to Rh positive blood cells can enter the fetal circulation where they attack and destroy the fetal erythrocytes. It's basically attacking the fetus. I have never seen a test question where mom is Rh negative and we tested the fetus to see if it's Rh negative to see if we don't have to give her RhoGAM. I've never, in the history of me teaching this, I've never seen it. Trust me on this. If she's Rh negative, you're expecting her to get RhoGAM. We're not going to take her word that she was never pregnant because she could have been pregnant and just didn't know. Early identification and diagnosis of Rh desensitization are important in the management and prevention of fetal compromise, fetal complications. A maternal antibody titer, you got to know what it's called. This is the Coombs test, the indirect Coombs test. The indirect Coombs test should be drawn at the first prenatal visit. Genetic testing allows early identification of paternal zygosity at the Rh gene locus, thus allowing earlier detection of the potential for isoimmunization. Amniocentesis may be used to test the fetal blood type of a woman whose antibody screen result is positive. The use of polymerase chain reaction, that's a PCR, may determine that the fetal blood type and presence of maternal antibodies, and the fetal hemoglobin and hematocrit may also be measured. Postnatal treatment is usually phototherapy for mild cases of hemolysis and exchange transfusion for more severe forms. Prevention. See, I put an NCLEX next to this, make sure you know it. The primary aim of therapeutic management of isoimmunization is prevention. The administration of Rh immunoglobulin, that's your RhoGAM, it's a human gamma globulin concentrate of anti-D to all unsensitized, what does it say, guys? Rh negative mothers after birth or miscarriage of a Rh positive infant or fetus, and it prevents the development of maternal sensitization to Rh factor. If she's Rh negative, she's gonna get it.
What if she's not tested yet and she's like in an emergency type situation?
She's gonna get it.
She's gonna get it?
Yes. So don't be tricked, because you're gonna see something about this, guys. I guarantee you. And they're gonna try to distract you, talk about the dad is this, the dad is Rh negative. How do we know? How do we know? The mom is the key. If she's Rh negative, she's gonna get the RhoGAM. The injected anti-Rh antibodies are thought to destroy, by subsequent phagocytosis and agglutination, fetal RBCs by passing into the maternal circulation before they can be recognized by the mother's immune system, and they basically attack the fetus. To be effective, RhoGAM must be administered to unsensitized mothers, Rh negative moms, at 28-week gestation and within 72 hours after birth or following miscarriage or therapeutic abortion. So let's say she didn't deliver, but she had a miscarriage or she had an abortion. If she's Rh negative, she should still get it. Because how often does it happen that a woman's pregnant and she doesn't even find out she's pregnant until she's several weeks along? RhoGAM is also given after any other event in which there's a risk that fetal RBCs can enter the maternal circulation, such as amniocentesis or external version. RhoGAM is not effective against pre-existing Rh positive antibodies in the maternal circulation. If she's already got in her bloodstream, the RhoGAM isn't going to do anything for it. RhoGAM is a preventative measure. Complications of preterm birth. Let's go over this table first, and then we'll talk about respiratory distress syndrome. Everyone there? Okay. Late preterm infant assessment and interventions. So let's talk about the risk factors. First risk factor, respiratory distress. You're going to make sure that you monitor oxygenation by pulse ox, provide supplemental oxygen as needed. Another risk factor, thermal instability. It is so important to make sure that there's skin-to-skin care in the immediate postpartum period. That baby's going to be placed on mommy's chest or on her stomach, no clothes, and then a blanket placed over them. Okay, skin-to-skin contact. Avoid excessive heat loss. Avoid draft. Another risk factor, hypoglycemia. You're going to monitor for those signs and symptoms of hypoglycemia. Avoid dextrose water or water feedings. This is a newborn. They need milk. If they have hypoglycemia, they're going to get that glucose how? IV. Avoid dextrose water or water feedings. Provide IV dextrose as necessary for hypoglycemia. Another risk factor, jaundice. You're going to assess for jaundice, especially in the first 24 hours. Make sure you're looking at the bilirubins. Feeding problems, that's another risk factor. Initiate early feedings, preferably breast milk. But if mom can't breastfeed, formula, but initiate early feedings. Provide assistance and support with feedings. Another risk factor, neurodevelopmental problems. You're going to assess for respiratory distress, neonatal jaundice, hypoglycemia, and last, infection. You're going to use universal precautions. Administer hepatitis B vaccine. They definitely have to have that, their first Hep B of the series before discharge. Encourage breastfeeding. All right, let's talk about respiratory distress syndrome. You know what that is. I'm moving over here to surfactant. Surfactant deficiency, that is the principal factor in the development of respiratory distress syndrome. Remember, guys, surfactant is what keeps that alveoli from collapsing so that the infant can survive outside of the womb. Surfactant is a surface-active phospholipid secreted by the alveolar epithelium. Acting much like a detergent, this substance reduces the surface tension of fluids that line the alveoli and respiratory passages, resulting in uniform expansion and maintenance of lung expansion at the low intra-alveolar pressure. This is what allows the lungs to expand. The administration of exogenous, when you guys see that word exogenous, that means from an outside source, not from within the body, right? They're getting injections coming from the outside source. The administration of exogenous surfactant to preterm neonates with respiratory distress syndrome has become an accepted and common therapy in most neonatal centers worldwide. The goals of oxygen therapy are to provide adequate oxygen to tissues, prevent lactic acid accumulation resulting from hypoxia, and at the same time, avoid the potentially negative effects of oxygen and barotrauma. Yes.
Can you go to the page before you had that?
Here?
The top of right there.
Oh, thank you. I completely missed that. Thank you. Clinical manifestations of respiratory distress syndrome. What are those signs and symptoms? Tachypnea, respirations more than 60 breaths per minute. Pronounced intercostal or substernal retractions. They're having a hard time breathing. Flaring of the external nares. Cyanosis, them turning blue or pallor. Them turning white. Apnea. And you guys can read the rest on your own. Respiratory complications. Meconium aspiration syndrome. So meconium aspiration syndrome. This is aspiration of amniotic fluid containing meconium. Remember, meconium is the first stool. That's what the infant is supposed to have within, the first 24, 48 hours after birth, not while they're still in the womb. So this is aspiration of amniotic fluid containing meconium into fetal or newborn trachea, in utero, or at first breath. Clinical manifestation, there'll be meconium stained at birth. Care management, you're going to monitor for respiratory distress. You're going to manage with supplemental oxygen as needed. Prevent acidosis and hypoxemia. Give them surfactant, exogenous surfactant, high frequency ventilation. Other nursing considerations, basically what you do for the patient for respiratory distress syndrome. Let's talk about post-term infants. Issues with post-term infants. Infants born after 42 weeks gestation are considered to be post-term or post-mature, regardless of their age weight. These infants display characteristics such as, you got to know this list, absence of lanugo. Remember lanugo, those fine hairs? Well, they've been baking in that oven for a little bit too long, right? These are post-term infants we're talking about. So they'll have absence of lanugo. They'll have little or no vernix caseosa, abundant scalp hair, and long fingernails. The skin's often cracked, parchment-like, and peeling. A common finding in post-term infants is a wasted physical appearance that reflects intrauterine deprivation. Depletion of subcutaneous fat gives them a thin, elongated appearance. The minimal vernix caseosa that remains in the skin folds may be stained a deep yellow or green, which usually is an indication of meconium in the amniotic fluid. Whenever I teach on this part about the post-term infant and what they look like, it reminds me, I don't remember the name of the movie, but with who's the guy that had the affair with Angelina Jolie and they got married?
Brad Pitt.
Yes, Brad Pitt. He did a movie, and I never saw the movie, but I saw the preview when he was aging backwards.
Benjamin Button.
Benjamin Button.
Yeah.
And in the preview, they show a clip of what he looked like when he was young, like just born, like the baby that looks like an old man. This is what it looks like. They look like an old person. All right, safety alert. Page 644, safety alert. Everyone there? It is unsafe to use scissors to remove dressings or tape from the extremities of very small and immature infants because it's easy to snip off tiny extremities or nick loosely attached skin. Solvents used to remove tape are avoided because they tend to dry and burn the skin. Signs of stress or fatigue in neonates. So in the respiratory system, we'll see tachypnea, pauses, gasping, sighing. Color, your color will be mottled, dusky, pale or gray. Flaccidity, they'll have low tone and trunk, limp, floppy upper and lower extremities, limp, drooping jaw, gape face.